Hello and welcome to day one, session two of the fourth annual Completed Life Initiative Fall Conference. We are delighted to welcome you to this session entitled In the Room, Challenges of an Accompanied Ending, a conversation with Jeanne Abbott, Thalia DeWolf, and Jeanne Kerwin. Welcome, Jeanne, Thalia, and Jeanne. Thank you so much for joining us today, and welcome to our audience. Stay tuned until the very end of the hour for a special announcement. And now over to you, Jeanne.
Thank you. And I would like to start by our disclaimer that Jeanne Abbott and myself, Jeanne Kerwin, we are both volunteers, members of the National Ethics Consultation Service for the American Clinicians Academy for Medical Aid in Dying. And as such, our interest in this particular ethical story or dilemma arose when we received a consult request through the Academy that highlighted the ethical tension between the professional code of ethics for nurses and the institutional policy that was in tension with that. So when we talk about medical aid in dying, we should really start by taking a look at the landscape of medical aid in dying in the United States. And there are 11 jurisdictions that medical aid in dying is one of the options for end-of-life care. This is a definition that has evolved. The original definition was very narrowly focused on writing the prescription and giving the patient the lethal dose of medications to take for themselves. However, as we evolved, clinical best practices discouraged this limited focus and isolated view and broadened it to really include evaluation and care of the terminally ill patient who was considering the use of medical aid in dying. So our current definition is much broader and I think much better. Medical aid in dying refers to the legal practice where a clinician cares for a terminally ill patient who considers and potentially follows through with hastening their imminent death through the use of medications prescribed for that purpose. So that's the current definition, and I think it has evolved in a positive way. So eligibility in the United States requires that individuals who are seeking medical aid in dying must be an adult resident of a jurisdiction with the exception of Oregon and Vermont, and we may see other exceptions as we evolve further, must be terminally ill with a prognosis of less than 6 months, similar to hospice, must be mentally capable of making their own healthcare decisions and have that decision-making capacity, must be acting voluntarily, and also must be able to self-administer the aid in dying medications. So both the definitions and the eligibility for MAID of note are different in different countries. This is just the United States, and you can see that Canada is very different. So these are the jurisdictions. If you can see them, I know that Hawaii and the District of Columbia are a little hard to see, but these are the 11 jurisdictions in the United States. But together, those 11 jurisdictions encompass almost 25% of the population of the United States, which is a quarter for those who are not doing the math. And so, of course, people in those jurisdictions have both institutions and patients have the right to opt out. So the Academy was the American Clinicians Academy for Medical Aid in Dying was established in 2020 after the first national conference on medical aid in dying, with a mission to develop evidence-informed best practices and education to support clinicians providing care to patients who are considering and or utilizing medical aid in dying. And I think this has been a terrific resource for clinicians. If you read the website of the questions and the concerns and the issues that are resolved, and it's been a great resource for clinicians. So the ethics consultation service for the Academy was established in 2021 due to the fact that we were recognizing that there were ethical dilemmas, no surprise, and issues arising with the practice of MAID that required the expertise of those who are trained and experienced in ethics consultation, analyzing and looking through the lens of ethics. So we currently have 11 professionals in a variety of different professions who are all trained and experienced in the delivery of ethics consultation and have an interest in serving voluntarily on this ethics committee. So we are available to respond to referrals that come through the ACA MAID website. And we're usually given a time frame if it's urgent or if it's an issue that can go for a month or so. And we have a whole structural procedure in process to provide those ethical consultation opinions and recommendations. We do not, of note, make any decisions. That remains with the clinician and the stakeholders of the issue at hand. So these are just 4 of the 14 consult requests that we have had since our inception, but all 4 of these deal with the issue of accompanied endings. And as you can see, I'll read the last 3, 2, 3, and 4. Ethical permissibility of requiring hospice discharge for clients who intend to pursue medical aid in dying. Staff disagreeing with institutional decision to support patients who wish to pursue medical aid in dying, and patients experiencing conflicts regarding aid in dying in a long-term care facility. The number one issue that's listed here, hospice policies requiring staff to leave the room during ingestion of the medical aid in dying medications, is what we are using for our trigger case today to illuminate the issue and to go through the process of the ethical analysis that we pursued. And so I will turn it over to Thalia to illuminate the issue with her story. Thalia?
Okay, so this case was, I was a night nurse, and in July 2021, I was working after hours for a hospice that was not opted out, that took a neutral but engaged stance on aid in dying. So our policies allow nurses in pairs to be in the home, but not in the room during ingestion, and only Monday to Friday, 9 to 5. So my managers knew that I was opposed to this policy, but they assured me that since I was a night and weekend nurse, that I wouldn't be caring for aid in dying patients. But death waits for no man, as we know. And so one night, I got a call from my triage nurse saying that there was an 89-year-old female with pancreatic cancer who had taken a sudden turn and wanted to take her legally prescribed aid in dying medications that night rather than risk waiting until the next day when she might not be capable of it. So I called, and first I just tried to answer her questions by phone, but she was really frightened that something might go wrong. And the family felt very unprepared, and they wanted a nurse to be there with them. And since there were no other staff members available that evening, I had to go solo. So when I arrived, I knocked on the door, and I remember I was saying to myself, I will follow the policy. I will follow the policy. I'm going to try to really follow the policy. And they welcomed me into the home, and I sat with them, and I carefully explained the preparation and the procedure, including how to mix the medications, because I was not allowed to do so, and what they could expect as death approached. What does death look like? Many people have not seen someone die, so part of my job is to prepare them. I also told them that we had a policy that required me to leave the room during ingestion. At first, when I told them that, they were confused. I mean, wasn't she going to be, well, dying? And wasn't I going to leave the room right at that moment? I tried to explain to them that the purpose of this policy was to ensure that I wouldn't be tempted to break any laws. They were silent. The patient herself burst into tears. I did my best to reassure them that all would be well. I helped prop her comfortably in her bed with her adult children by her side, but they were all clearly terrified. I didn't know exactly what to do. So I stood, shall we say, more than 50% out of the room, sort of in the doorway, but mostly out, like where was the dividing line? Didn't really know what to do. And I saw the patient take a few swallows of the medication, but she didn't finish, and she began to cough and sputter loudly. She panicked and reached her hands out to me, and I went to her. I took her hand and I told her to take some slow, deep breaths through her nose. Her coughing slowed. I reassured her that she'd fall asleep once she had finished the meds, and she did finish the meds. She took a few more swallows, closed her eyes, and went to sleep. After 5 minutes, she entered coma, meaning she was really, really not wakeable. And 40 minutes later, she died very peacefully with my hand still in hers. I told her family that she had died, and I comforted them for a few moments, just as I have with many of my other hospice patients. Then I quietly left the room to go chart what had happened. 2 days later, I was fired for violating the policy.
I don't think this narrative, this beautiful and sad narrative of Thalia's would have happened if it had been with a less experienced nurse who has shepherded many people through made in dying in other situations and with other institutions. So the question that we asked as the consult committee was, why do policies like this one that Thalia experienced happen? Why do these patients' experiences fall so short of the mark? And why are institutions so hesitant and have oftentimes these policies that constrain the staff? So all of the laws in the various states, and each state writes their own, but they all have some kind of boilerplate, and they're typically written by risk managers and administrators rather than by medical professionals. And they've been cloned from one state to another. Here is a couple of models. Nothing in, and they to say that nothing in this part may be construed to authorize a physician or other person to end an individual's life by lethal injection, mercy killing, or active euthanasia, and this is not considered suicide, assisted suicide, homicide, or elder abuse, even though you and I know that that suicide word, which is so electric, is seen throughout discussions and conversations about this. The whole problem goes back to 1997 when the feds said federal funding can't be used for assisted suicide. And they've reiterated that in 2021. saying we remind hospices that you are prohibited from providing or getting paid for anything service that might cause or assist to cause the death of any individual, including mercy killing, euthanasia, or assisted suicide. So even though all the states say, no, wait a minute, this process, this allowance that is legal to allow made in our state or jurisdiction is not suicide, what has resulted is a whole variety of institutional policy statements. From one example, a Colorado hospice says staff may be present before, during, and after self-administration, but may not be present in the room during the preparation or ingestion of medications, which is what Thalia found in her hospice in California. All the way to a hospice in Hawaii who says staff may be present and articulate that at the time of ingestion if the patient and family so desire. So what we're left with is a whole hodgepodge. Every state allows opt-out for the institution, whether it's a hospice or a healthcare organization. One of our colleagues on the ethics consult committee, Chuck Miller from Hawaii, was very proud of the fact that he knew that everybody, all the hospices in Hawaii, opted in. But then he went and tabulated with the help of Compassion and Choices, and this was updated last year, to find out how many of them actually do allow staff to be present at the time of ingestion, and how many of the physicians are allowed to be the consulting physicians. So what he discovered, all the red circles are places that do not allow these policies. And so what he discovered is this range of policies that what it means to each institution to opt in. So fully opting in, staff can attend as they wish. Or there can be restrictions as to whether physicians can write prescriptions, whether they can be the consulting provider, and whether they can attend at ingestion. The same with the rest of the staff. And in fact, some of the opt-in policies include you need to be discharged from hospice at the time of ingestion. So there's a whole hodgepodge that has resulted from the fear of running amok with the federal regulations from 1997. In fact, the Completed Life Initiative has published a research project, and it's in your references, looking at California last year, since California did an interesting update of their 2015 law to reduce barriers for patients by shortening the waiting period and clarifying that aid meds can be administered in any healthcare facility. But particularly pertinent to us is the fact that healthcare entities were required, as of 2022, to publicly disclose their end-of-life policies and services on their websites. So they looked at this group of researchers, which did include Sarah. Your name wasn't on this, but it included you, looking at the web pages after a year after this Senate bill was passed. And less than half of the hospices on the web pages had any reference to their policy regarding aid in dying. And of those 41% that did mention it, less than 60% provided clear and specific information about what was allowed and what wasn't. This makes for a lot of confusion and a lot of problems for patients that Thalia is going to talk about in a minute. Sarah, you want to make a comment on the study that you guys did, which really was helpful? And this is a hi from Breckenridge this fall.
Great photo, and thank you, Jeanne. And I also want to give a shout out to Gianna Strand, Karen Zopek, and David Hoffman for their co-authoring of that research project, which we also went ahead and published in the Hastings Center Forum. looking at how the transparency of what's actually published on hospice web pages is certainly not adequate in terms of supporting patients in their decision making. And we hope that our research will offer enhanced transparency towards improving these policies moving forward, and ideally looking at every state where MAID is legal and examining the current or lack of transparency on those websites moving forward. So certainly a lot of work to be done. That's the tip of the iceberg, but it's got us going in a great direction.
And
We have a question from the audience. David writes, Thalia, were you given a chance to explain your reasons for re-entering the room where the patient was?
So I was, and in my chart notes, I wrote rationale about why I needed to stay in the room, that the patient had aspirated and needed my nursing attention to come and reassure her and comfort her. And I was interviewed, and I thought I wrote a pretty compelling narrative. It was pretty clear that it wasn't just like, oh, I think I'll just stay in the room. I mean, when people talk about this too, they'll say, if the family wants you to stay in the room. Well, I would take it a little step further and say, what about informed consent? Do family really understand the value of having a person be, even just in the background, available during the death and dying process, which even medical aid in dying, those signs and symptoms of dying do not disappear. So I was given the chance, but I was met definitely with a kind of a cold shoulder. Like, this was the policy, you knew the policy, you should have left the room. Even if she aspirated, you should not have gone back in the room, is basically what it came down to. But I mean, I treated this patient as I would have any hospice patient. And I charted it. I was told later that if I simply hadn't charted it, it would have been okay.
that's one of the scarier things, Thalia, I think,
Yeah.
is that I think the advice you got, and we've heard this from others, is you just don't chart that.
Yeah. Just lie, basically.
So it's shocking, and also, I think you did the right thing in terms of stepping in and offering compassionate support to the patient. So thank you for being that brave soul to do the right thing. Are other people seeing issues like this? Is this more widespread than, say, N of 1?
My sense is, and I do hear this, nurses will sidle up to me even after I was fired. People called me and were like, oh, we're so sorry this happened to you, but we just don't say anything. That there's a kind of secrecy and a kind of fear for a lot of staff members. So will they admit that they've stayed in the room? Probably not. So I mean, I don't have the evidence to totally back this up, but it's anecdotal. I have a lot of anecdotes, not just nurses, chaplains and social workers. We bond with our patients pretty deeply. So, and I think it's not uncommon for patients and families to be rather shocked. Like, who invented this policy? What a weird policy. And do you spin around on your head and touch your nose 3 times? I was just like, oh, leave the room right at the moment that I need you the most. So anyway.
I can just add to that Thalia's story. I think it's so important because I think this is how policies and laws evolve. If we challenge them and sometimes get in trouble for doing that, that really does move the needle. If you look back in time, I spent many years as a paramedic, and in the very beginning years, we had no out of hospital DNRs. There was no such thing. So you would get into a home and somebody would say, oh, please don't do that. He's 95. We expected him to die, but we called 911 for help. And so I didn't get fired, but I did refused to do resuscitation, and I documented it. And I then made up my own like piece of paper that said, do not resuscitate. And we piloted it in a small area to say, so I applaud what you were brave enough to do. And unfortunately, it led to, the response of your employer, but you're making change in a big way. And that's what really counts. Otherwise, we would still have slavery if nobody challenged it,
That is
right?
true. I think I was on the committee, the Aid and Dying Policy Committee that met once a year, and I was hoping to change the policy that way. I didn't actually intend to be a rebel by any means. And I have heard of another hospice that when the time came for self-ingestion, a bunch of the nurses and social workers stood together. It has to be more than one person. So people standing together and saying, we can't wait a year for this policy to change. This is just wrong. But I didn't get that kind of support. The doctors and nurses didn't stand up with me. They were scared. They called me days later and were like, we're so sorry, but we can't lose our job.
Yeah, sure.
So it sounds like the support of a interdisciplinary healthcare team would have been perhaps more of a roadblock to facing, the power of that hospice policy to kind of come down strong on you. What might be a nice pivot point for future policy for hospices moving forward? How do we reframe the narrative to better outcomes?
So I have noticed, I did a survey, an anonymous survey of hospice nurses. And what I found is though the policies don't change, they soften. So like there was this policy, I call it the don't ask, don't tell policy. If the patient doesn't explicitly bring up aid and dying, you cannot talk about it. Well, how that softened is that we started asking open-ended questions, and we started agreeing that if the patient didn't use exactly the right language, you could clarify with them. So in terms of staying in the room, it softened in that there was like part of the policy was like, oh, if only if you can stay in the room if it's medically indicated. And so, I think what started to happen for nurses is that they basically stayed in the room and didn't chart it. And then over time, that policy sort of has faded out of policy. Not very much, not completely. It's still the vast majority of hospice that's in their policy is the nurse has to leave the room. So what do I think? It will have to soften. There'll have to be rationale. I mean, I think one of the things that cut me off too, because this is like my thing, but I think that people who have been at the bedside have this experience. I think policy writing that includes providers who have actually been at the bedside so that they can give some of those, significant points of information and wisdom. If you've never been at the bedside of a patient who's taken aid and dying, you might not know how important it is for a nurse to be there, a staff member to be there, to normalize the signs and symptoms of dying, and to comfort patients if they aspirate. So it's a matter of experience ultimately, but it's I don't know. It's slow. I try to have patience, but I think all stakeholders at the table when they make policy, and the policies need to get reevaluated regularly.
Well, and you're also stepping into that role of a doula as well. It's a nice, beautiful merger of those two, and they ought not be distinct from each other. They ought to be complementary and integrated. So thank you for that.
Yeah.
Back to you, Jeanne.
Okay, why did the ethics committee get involved in this from the ACA MAID group that Jeanne and I are a part of? Well, we thought this was an ethical dilemma. that general principles of all of the professions, physicians, nurses, chaplains, all healthcare professionals, include something about the fact that we have a fiduciary commitment to put patient interests first, an obligation to avoid patient abandonment and to provide for patient safety, and to step aside on the basis of conscience only if there's equivalent or alternative care available to the patient. And in fact, there are specific things. Nursing has actually been the lead in this. I can ding the AMA as a physician myself by saying that they have waffled in their neutrality and pros and cons of understanding everything. But the ANA nursing position has been pretty clear that you shouldn't abandon or refuse to provide comfort. And when making a decision on whether to be present, the nurse should consider personal values and organizational policy, which Thalia certainly had to reflect on, as well as the relationship that exists with the patient and the family. And that the nurse needs to promote patient dignity and provide symptom relief, comfort, and emotional support. As Thalia points out, these are professional skills and their professional responsibilities. And in 2007, the Hospice and Palliative Nurse Association actually came out and said nurses must not abandon patients who request physician aid in dying or physician assisted suicide, as they were still using the term. So we came up with an ethical analysis of this. And Jeannie, you're going to do this, but we balance the pros and the cons and try to look at it from all the different perspectives. How did we do, Jeanne?
Yeah, well, I just want to start with what we all experience is when we hear a story like Thalia just told us, we all have like a gut response, an emotional response to say, oh my gosh, that's wrong, or oh my gosh, of course you did that, or you didn't do that. And I think as clinical ethicists and our whole team, being trained in ethics is to really kind of take a time out and say, okay, we're gonna this is the way we feel our gut response, but we're gonna take a deep dive and be fair to both sides of the issue. If there's two sides, sometimes there's more, and we're going to look at the arguments for it and against it, and where those, as Jeanne was articulating, where some of those arguments come from. They come from laws, they come from policies, they come from experience, they come from mythology, but we really need to look. So what our process is as an ethics consult team when we hear an issue like this is not to jump into our gut response. It's to follow our process. And how we do that is by looking for and defining, first of all, what is the ethical question? Because a lot of questions that come in the hospital ethics and other areas are not ethical questions. They're legal questions or risk management questions or discharge planning questions. But we had to define the ethical question. And defining that then gives us a focus to then analyze it. And we did this by looking at institutional arguments for being in the room and participating, not in the application I made, but helping the patient, and professional ethical reasons and principles about why it's for. And in the next slide, you'll see we also looked into those arguments that are supporting why some people think it's not the right thing and are against it. So after we did our analysis and looked at all these things, I'm not going to go through them because it was how many hours, Jeanne Abbott, did we spend? We went into federal law and local laws and policies and ethical principles that supported and didn't support it. And ultimately, we came up with, I don't have a slide of it, but I will read you our position and our opinion and our recommendations. So if I may read that, we acknowledge the appearance of tension. This is sort of a precursor between nursing professional ethics and legal duties not to abandon patients, and the right of healthcare entities to define and enforce their institutional values. It appears that these policies are often shaped and motivated primarily by legal and risk concerns. Our opinion. We believe that this case depicts the compromise of a single ethical principle, professional commitment to reducing suffering and non-abandonment of patients for the sake of risk management concerns. It is our opinion that even if hospice policies requiring a nurse attending to a patient to leave the room during the ingestion of aid and dying medications, even if those policies are legally permitted, it is not ethically supportable unless it's at the patient or family request. And so I always point this out, and I think it's never more clear as a key point than in this case, is that what is legally permissible is not always ethically supportable. And contrary, what is ethically appropriate is not always legal. So this is the tension that we see in our society, and very particularly in a lot of healthcare ethical issues. But that was our opinion, that we found that policy to be not ethically supportable.
You know, this is me being, you know, maybe a slightly a bossy nurse, not really, but my, you know, time since being involved with patients who were considering aid and dying and being involved with hospice patients, there's a threshold before a patient enters a hospice when they, you know, are trying to figure out, you know, what they want for their last chapter. And what generally hospice clients or hospice patients have found is that policies are vague. They're not easily located. They're not on websites. By vague, I mean, they'll say, we take a neutral policy. We will not, you know, interfere, but we will not, you know, it's vague. There's no real, like, there. There's none of the details that patients really need typically, not even from the admission nurses. There's minimal information about aid and dying, what it actually is and is not, let alone what the agency's policies are before admission. There's typically, so I divide this into two layers. There's the doctoring layer, and then there's the sort of the nursing and staff layer. So in the doctoring layer, there's typically restrictions about, you know, whether the doctor can prescribe and or consult, but most patients don't even know to ask that. So the restrictions on nurses and staff, typically they're not, there's this don't ask, don't tell policy is really typical, meaning do not initiate the discussion or provide any detailed information unless the patient is explicit, which is, you know, I think disables informed consent seriously. There's typically no guidance or preparation about what aid and dying, what the procedure is like. And so families think that it's super, super easy. It's like, you know, no big deal. And actually it can be fairly complicated. There's no assistance or information on how to mix these very dangerous medications. There can be no attendance sometimes from staff, or the staff have to leave the room. And even some hospices have required that patients be discharged from their hospice before they self-ingest. So here is me being like idealistic. What policies would foster better care? Because that is the goal, while staying within the law and meeting the agency's needs, fiduciary needs. So the first thing I would say is policies need to be updated with staff, bedside staff input, updated at least yearly. And the staff need to be educated at least yearly and easily, you know, like give them some time to, and not just the legal requirements. What are the practical requirements? What are the requirements that patients need? And I would say, in summary, allow licensed staff to act within their scope and within the law. So allowing your doctors to prescribe, consult, and provide care seems legitimate to me. Allowing your nurses and staff to discuss aid in dying as needed and freely with the patients and families without fear, I think is really important. And facilitating good monitoring and preparing of patients and families so that the aid in dying procedure goes smoothly without complication and that families are better adjusted. I think allowing nurses to manage the dangerous medications as we do really dangerous medications. And think about it. I'm going to be trusted with 400 mics of a fentanyl patch, but you're not going to trust me not to pour the aid in dying medications down a patient's throat. It's kind of, I mean, I have a license that I'm protecting. So, and I think staff being at the bedside during a planned death is just good care. It may not be totally physiologically indicated, but certainly emotionally. And I think we've even had a few cases where families have called 911 because patients are having normal signs and symptoms of dying, and it's just frightening. So having staff at the bedside is going to be beneficial for everybody. What are the questions that patients need to know before they get admitted to hospice? So one, are your staff educated and supported to provide aid in dying care? Not aid in dying, aid in dying care. That's the continuum from the moment that they consider aid in dying through whatever their death process is like. What can your doctors do or not do? And do they? Like some hospices are like, yeah, we let our doctors prescribe or consult, but then there's not someone on the staff to do that. So can and do your doctors prescribe? Can they and do they consult? Can they support? And then the nursing layer. What can your nurses and staff do or not do? Can they provide detailed information? Can they monitor and prepare patients and families? Can they mix the medications or at least coach a family on how to do that? Can they be present? Can they stay in the room? And then finally, does your hospice have specialized grief support or spiritual care? There is a phenomenon we call disenfranchised grief, which does happen for some families where they feel like they can't talk about their loved one's death openly because they worry that someone might be offended that their loved one took aid in dying or might be shocked. So having good support, grief support and spiritual care, those are essential ingredients. Thank you.
So here we are at the conclusion and opening it up to you all. Thalia actually helped me to understand that the original model way back from Tim Quill and 20, 30 years ago was, I'm sorry, that was before you were born. I know that, Thalia.
Yeah, but I still adore him, like, he's amazing.
And that the original model, as you have pointed out so bluntly and well, is that this is a kill pill on the shelf and that people can just take it in a few months when they're ready. And that is not professional and is not the way things have played out. This is a complex procedure. This is there are evidence of best practices, not just for physicians, but for nurses. And it's a complex procedure that's not without risk. Every institution in every jurisdiction where aid in dying is legal has the option of opting out. So they have a strategy if they are not comfortable with this. But as Jeanne pointed out, although we grappled with this as an ethical dilemma, which is usually a dilemma between a couple of things that could be right for different persons or entities, we ended up concluding that this is an ethical temptation. It's a temptation between what is right for the patient and what people are doing that isn't right. Because it was hard to find justification other than the legal fear, which has never actually played out, that hospices will lose support from the feds if they fully support aid in dying and participate in it. But professionals really do have an obligation to put patient care first. And if an institution says we are going to opt in, our feeling is that this is very worthy and it's very important that this be handled as a professional experience, not just a one-off thing, but a professional experience in journeying with the patient. From entry into hospice, knowing that this is a possible choice, and through the end of the procedure and the grieving that occurs afterwards. So Sarah, I'm going to turn it back to you. We did have some references that we'll post, I think, on your website, right? And go to whatever questions and comments people have.
Indeed. Thank you all so much. I'm really struck by this idea of there is no disclosure on the hospice website of any kind of option within the spectrum of options for your death, whether that's no intervention, to palliative care only, comfort care, to medical aid in dying. And I know we have a slide about the spectrum of from each end of and everything in between. Can we pivot to that slide? And would you mind walking us through what these options entail and what could potentially be the normative standard for hospices to present as a policy on their websites moving forward?
Sure. I was impressed with Jessica Zitter's talk this morning about the very rapid ethical movement in this country among healthcare professionals that go from 20 years ago of, you couldn't not start CPR. You remember she talked this morning about the fact that it was shocking the first time that somebody asked her to withhold a life-sustaining treatment. We've eventually evolved to being able to withdraw life-sustaining treatment, which interestingly enough feels a little different than withholding life-sustaining treatments because it's sort of an active thing that healthcare providers do, to now considering it acceptable to voluntarily stop eating and drinking and sedation to unconsciousness. And we have our quarter of the population where it is legal, ethical, and acceptable to do medical aid in dying. We are not a country where it is acceptable for the healthcare provider, the physician, to inject or give the medication that causes death, even though in other countries that is considered acceptable. And frankly, in Canada, 99+% of people want IV sedation to dying. It is a very much more secure and safe thing, but that's not yet where the United States is. So where should hospices be? They have clearly embraced the voluntary stopping eating and drinking and sedation to unconsciousness. I'm on an ethics committee of a hospice here, and we do ethics consults as a cross-check when somebody wants to do VSED or sedated. But I still live in a world where people have to step out of the room with this fear of medical aid in dying causing a threat to the institution.
And Jeanne, if I can just add to the evolution that we've seen, a lot of the evolution forward has been driven by court cases. Karen Ann Quinlan in 1976 was like a very internationally known court case that went to the New Jersey Supreme Court to allow Karen Ann Quinlan, who was 21 years old and in a permanent vegetative state, to have her parents agree to withdraw a ventilator. And it was unheard of before that to withdraw a ventilator from somebody who was not permanent. She was in a permanent vegetative state, which is a new, but not terminally ill. And so a lot of it went to the courts for court case history and then set a precedent for the next. It was in 1990 that they agreed that a feeding tube was equal to a ventilator. So it was like step by step through cases. And Thalia, you've got a case. So it's cases and stories and narrative that bring it to light and help change policy and law and practice in medicine.
And when you think about this, that's actually a pretty fast time warp for
Yeah,
wrapping our heads around the ethics of dying. But
yeah,
medicine has also moved fast. And I would say also that much of this is grassroots,
yeah,
because we are seeing patients who are saying, who are calling their hospices and saying, do you support medical aid in dying? And we in our community have hospices that say, well, we're sort of neutral, like Thalia was saying, they're wishy-washy about it. And they will move to a different hospice that says, yes, we will be there and we will accompany you on the journey.
yeah. And I think medical technology doesn't, it advances so fast that we don't have parameters. At the height of COVID, nobody had a notion about when could you stop ECMO? Could you stop ECMO? And that was like a new parameter that we had to figure out how and when would you stop doing ECMO, which was total artificial lung and heart support. So it's an evolution, and those of us who are old enough to remember Timothy Quills being charged by the Attorney General for, providing a patient with a prescription long before medical aid in dying, but incremental stories and cases are what drives us forward to a different era.
I sort of say that it's very patient driven. Medical aid in dying is something that I think patients have nudged forward in a way that, technology, it wasn't even top down. As a hospice nurse, I can tell you that before aid in dying was even legal, a lot of patients, 50% of my patients or so, would sidle up to me at some point and say, hey, when I get close, you think you'll be able to help me out? And I used to have
Yes.
to say no, but I know I can keep you comfortable. And now I can say, hey, tell me more about that.
Yeah.
Are you talking about maybe wanting medical aid in dying? I can give you some information.
I just have to interject because I'm old enough to remember working in the hospital when on the oncology floor, there would be patients that were quote unquote put on a morphine drip. And the clear end point for that was dying. And it was never called expediting death. It was sort of undercover. But you would go on to the unit and they'd say, oh, that patient just got put on a morphine drip. And
It's the second effect, right? Where the goal
yeah,
is to keep the patient
yeah.
comfortable. And
So, yeah, it wasn't
secondarily, yeah, I mean, it's
because
that's the ideology.
we didn't acknowledge that death was expected,
Mhm.
even though that was the purpose of the morphine drip.
Yeah.
But so we've come far away from dishonesty and cloaking it to calling it what it is.
Yeah.
Well, and that's been an incredible cultural shift away from a death averse society to where it's more open to be acknowledged and discussed. And yet, um, it, despite that updated status, we still have a long ways to go. And Thalia, I echo that it should be driven by the patient. However, from an equitable perspective, to Jessica Zitter's point earlier today in session one, patients who don't have the resources to fully immerse themselves in what's possible for them ought to have the ability to step forward and be informed, and the hospice ought to meet them at that point.
Mhm.
So thanks, Jessica, for reminding of that up to us earlier. One last question before we conclude. I'm wondering, what can the Completed Life Initiative do to call out those hospice agencies that interfere with clinicians fulfilling their ethical obligation to provide care and to laud those who don't.
So I've been thinking a lot about this, that to solicit change requires some empathy. So it's one of the reasons why I really like the ethics consults that we've done, is because there's like an openness to examining what are the forces on hospices that are making them feel like they have to make these policies. So if we can really understand that and not just say, oh, well, you're just wrong, but really understand that and maybe help guide them to, with other models. For one, I think having hospices come together to talk about their policies about aid and dying and seeing the diversity that is possible, I think would be, I think that's a very constructive, would be a constructive mechanism. And just keep doing what you're doing, which is to bring to light all of these possibilities, ultimately.
And I think, Sarah, that hospices, I think the kind of work that you're doing in terms of monitoring, how often are hospices putting things on their website? What is happening? But I do love Thalia's idea of getting them together. What is really the risk to them? Well, how do we change this 1997 law that seems to paralyze them? And has anybody really ever had their funding removed? Because they do get 80% of their funding from the feds at least. And so, they have some fear.
I will tell you, the Academy's journal is going to have an article about ASPRA discussing it in detail. So there'll be some, we're going to keep all of us together in community, keep working on this, keep trying to understand, I think ultimately is crucial.
Well, thank you for that. Beautifully said. And Thalia, thank you so much for your boots on the ground work by the bedside with patients, and Jeanne for your insight and your contribution with co-authoring this article on hospice nurse ethics. And so for anyone interested in reading the full article, we'll put the link to the PubMed publication in the chat. And so thank you so much for that article. It was an incredible read. And it highlights this issue of the story that Thalia described earlier in detail. So thank you so much to Jeanne Abbott and Thalia DeWolf and Jeanne Kerwin for an incredible presentation today. For additional reading, please check out this article. The notion of do no harm reverberates for healthcare professionals like Thalia every day. And what does it mean to keep a patient safe, especially when they are dying? When a patient lives in a jurisdiction where aid in dying is legal, hospice facilities face scrutiny from the inside and out, as you've heard today. How ought a nurse best support the patient when that patient opts for assisted dying? Can the nurse stay in the room, as Thalia chose to do, after the patient ingests the medication? What is a nurse's obligation in their caretaking of the patient, ranging from respecting the patient's wishes, ethical non-abandonment, and confronting a range of stigmas, stereotypes, and conflicting viewpoints? The moment that our team at the Completed Life Initiative heard the story about Thalia's patient and Thalia's courageous actions on behalf of the patient, whom she refused to abandon at the bedside, we immediately recognized her commitment to her patients as incredibly courageous. As a hospice and palliative care nurse in Northern California, Thalia is devoted to providing attentive care to terminally ill patients until their last breath. This professional commitment once resulted in her hospice employment being terminated, as she refused to abandon a choking patient during the administration of medication during the aid in dying procedure. Thalia continues to call upon hospice providers to fully support those who choose medical aid in dying by allowing the presence of all staff members to be in the room if that is the request of the patient and family. Thalia, thank you for your steadfast courage and commitment to your patients. It is an honor and a privilege to present to you the first ever Completed Life Initiative Courage Award.
Wow. Oh my goodness. Thank you so much. Wow. I'm flattered and I'm honored. And for all the patients that I've been at the bedside, I have to also thank them and their contribution to my sureness that this is the right thing. Thank you. Wow.
Bravo.
Round of applause and thank you. So what a way to end,
Thank you. Thank you.
the session. Yes. Thank you all so much for tuning in. That concludes today's session. We look forward to seeing you this evening for session 3 with our keynote with Amy Bloom. Thank you and take care.
Thank you.
Yeah.